are officially live. So here we go. So
All right, great.
welcome, Dr. Phil Lahey, Worcester County Orthopedics, orthopedic surgeon, team doctor for St. John's High School, Holy Cross College. And Phil, I'll let you kind of, take it away, introduce yourself a little bit more.
Yeah. So I'm one of the team doctors for Holy Cross. We have a great team of physicians, including Dr. Vin, who's our head team physician, my partner. He's a former Holy Cross football player and our longtime partner here at Worcester County Orthopedics. We also have Dr. Brian Bisconi, who helps us out a lot from UMass, and Dr. Jay Broadhurst, who handles the primary care side. Great, awesome sports medicine team up there, along with the great trainers who help us out every day up there. So I don't want to forget them.
Yeah, absolutely. That's an all-star. That's an all-star crew up there. So. Great. So we are talking all things knee today. So any attendees who join us, feel free to just type your questions in the box, and we'll get to them, a little bit later in the talk. But let's dive right in, Phil. So I think one of the big things that patients come in to see me with, in particular, beyond the diagnostic ACL tear, MCL tear. The things that are pretty easy to treat because we know what's going on. We have MRI confirmation. It's just that everyday, nagging, achy knee pain. So the number one question that I get at parties or, up at the club or whatever is, when do I do something about it? So how do you have that conversation colloquially, and how do you kind of work through that with your patients?
Yeah, it's tough. Knee pain's really common. I mean, really common. If you look at big studies, it's like a huge percentage of the population every year will have some knee pain that they either see a doctor for or don't even see a doctor for, just on their own. They just treat it with a little Tylenol or Advil or something. So yeah, when does it rise to the level of needing care from a physician? And I think the rule of thumb that I tell people to, just in daily life, not even in the office necessarily, because then the choice has already been made, they're already seeing me. But for my friends and family, I think that when it starts to affect your ability to do the things you normally do, like if you're doing everything normal and you notice a little bit of soreness here and there, that's probably not too bad. And it's probably pretty normal to feel that once in a while, especially as we get into our 50s and 60s, certainly beyond. But if you're saying, geez, my knee is bothering me so much that I can't really play golf the way I normally do. I certainly have to take a cart. I can't walk, or I can't exercise the way I normally do. I can't go for my walks. I can't use a treadmill. I'm having a hard time at the gym, working out the way I normally do. And I'm going to have to change my activities to handle this knee problem that I'm having. That's when I think you should probably at least have somebody take a look at it or talk to, maybe even just your primary care, but starting somewhere with a medical person to try to get a sense of what's going on. Is this worth exploring further?
Yeah, and let's talk through just by age range, right? So let's say you're, let's break it down like 20 to 40, and then maybe like 40 to 50 to me is like that gray area, right? So you're old enough to have degeneration, but you're not really, and you're still thinking maybe, and I'll let you kind of dive into this and your thought process and your brain. The patellofemoral pain syndrome, which we both know is a diagnosis of exclusion. We kind of go there when we're like, it's just mechanical, whatever.
Right.
Versus really, kind of that older knee, 50 plus. So I want you to kind of talk about diagnostically what goes through your brain when people come in with just knee pain. They're 20 to 40 years old, or even younger.
Yep.
Well, the younger is even that's a different can of worms. We can get
we can talk about that. I treat kids as young as first, second grade. So the first thing I do, and I think this is important, all doctors probably do this to a certain degree, but you got to listen to the patient. I really want to listen to their story, hear their complaints, find out how this all started, find out if it was from an injury or it just kind of started on its own randomly. That tells us a lot of information, just getting the history. And so opening your ears can really make a huge difference. If you're in that 20 to 40 range, you had a totally normal knee, and then all of a sudden your knee starts hurting. Was there an injury? And often there is at that age. It's pretty rare to get sort of random knee pain that starts up. You wake up one morning, your knee's sore, you have no idea why. That can be a little more common as we get into our
All right, perfect. All right, so we were talking about 20 to 40-year-olds and then like
Yeah.
kind of 50 plus knee. So let's dive right in there.
So with the 20 to 40-year-olds, there's often an injury history. And if there is, that keys me into thinking, okay, otherwise normal knee, but something happened. And so then it's down to physical exam after we hear the story. And so if the physical exam then starts to reveal certain things, and there's certain kind of physical exam kind of findings, pain along the joint line when we press along the edge of the joint, or that pain with sort of twisting the lower leg, if you turn the ankle and the foot and it causes pain up in the knee, those are kind of classic findings for a meniscus tear. And so then we're thinking more, hey, maybe this isn't just arthritis. X-rays are also a piece of the puzzle. If you look at an X-ray, the X-rays look pretty normal. The joint spaces are pretty well preserved. There's some good cartilage there. But we have pain in a specific area. That really clues me into thinking there's a problem in that specific area that's likely to be a meniscus tear. We're also checking in on the physical exam for things like ligament injuries. So if there's any instability in the knee, we're going to feel that when we stress the knee in different directions. And so we're going to feel if there's MCL laxity or looseness, that's going to be a signal that there's an MCL sprain or something like that. If the ligaments all check out and they feel solid and the knee feels stable, but we have that reproducible pain in a certain area, then a lot of times our next step, just to back up a little bit, the X-rays are great at looking at the bones, and it's like a picture of the skeleton. We can make some guesses or inferences about the cartilage by looking at the space between the bones, but we really can't see the cartilage in detail. And so in order to do that, our next step is often to get an MRI. And so MRI imaging is going to look at the soft tissues and look at the cartilage in a lot of detail, and we're going to be able to see meniscus tears. We're also going to take a look at the ligaments and see that any damage or problem with the ligaments. And it's going to give us a nice three-dimensional view of the whole inside of the knee.
And I think a great point there too, Phil, is just, and a lot of patients ask me, right? So a lot of times they go from your physical exam, so it starts, either an MOI, I tripped and fell, or soccer, I was playing soccer and, twisted, contact or non-contact. Then they go see you, right? Or they come see me and then they go see you and they come back to me. So the common question is, right, when do I get an MRI? So that's common with the knee, the low back, and the shoulder. But specifically for the knee, after you send somebody to a PT, how long are you expecting them to do PT before, that you send for an MRI? Or do you kind of just send for an MRI right away, or it just depends?
So I probably jump to it maybe a little earlier than some. I think primary cares tend to be a little more conservative. I feel more confident sending a patient to physical therapy with a very specific diagnosis. Yeah. I don't really like sending them to PT with just knee pain as the diagnosis, because that doesn't tell you anything. It doesn't really tell the therapist what needs to be done. Right. And while we can make some guesses and we can say, well, it's probably this, I'd rather say with more confidence, okay, we know that it's a meniscus tear and we're going to try some PT first, or we know it's arthritis, or we know what's happening. And so I tend to trigger the MRI when there's certain specific findings, both in the story from the patient and the physical exam. And so if the X-rays look pretty good, the physical exam is consistent with a meniscus tear or cartilage tear or ligament tear, like something structural. If there's some structural things on the physical exam that I'm concerned about, and they have a story, especially of a history of an injury, and those three things together, I'm going to say, yeah, we need to know structurally how the knee looks on the inside, and that's going to be done with an MRI.
And I think that's helpful for us as PTs too, because when I look at a script with PFPS on it, or for the crowd, it's, that's just patellofemoral pain syndrome. That's somebody who hasn't had an MRI 99% of the time, because it's, all of their exam findings and what Dr. Phil was talking about was, he's looking at the MCL, the ACL, the LCL. He's looking at the patella and the mobility there, and everything's coming back pretty normal. But the patient is still having pain, and there may not have been an MOI or a mechanism, right? A bend and a twist or a fall. So that's if you can send me, hey, listen, Sean, this guy has an MCL, or this guy has medial meniscus tear, which we know PT will help a lot, right? Depending on their age and whatever other comorbidities or factors. But meniscus tears, I would say, depending on age, right? A young meniscus tear is going to do fine on PT unless it's a really nasty type tear. So let's talk about that too, because that's another common theme, right? So we get a lot of meniscus tears better, and there's a lot of research showing that, you know, VMO strengthening, the classic PT, good manual therapy will help with that. What is your thought process on just going in to do like a scope for that meniscus tear? Like, what are you looking at in the different, like, is there a certain type of tear you're looking at more success with, or?
Yeah, so morphology of the tear is important. And so looking at types of tears, if there's large displaced pieces of the meniscus that are flipped down underneath, sorry, I'm like putting my hands in front of my face, but if there's a big piece of the meniscus that's really flipped over and displaced, bucket handle tears where there's a big flap of the tissue that's flipped over, you know, tears like that, I think do much better with the surgery, because there's going to be some mechanical blocks to movement that won't really be helped by physical therapy. But those are relatively rare. I mean, we see many more kind of small tears, kind of horizontal tears that are sort of in plane with the meniscus, or a little partial tear on the outer edge. And those do often do well with physical therapy. And I think that there's certainly a role for trying that first with these kind of smaller tears. And I will offer that certainly to patients. It also depends on the patient's preference too. Some patients have been dealing with the pain for 6 months and it's getting worse, and they're ready for the surgery. And I think it's appropriate at that point. Other patients, it's only been like 2 or 3 weeks, and, you know, the pain is it's there, but it's not that bad. And I say, well, let's not jump to surgery as the first thing we try. Sure. You know, we'll try some physical therapy first and see if it works. And if it does, that's great. We can avoid a surgery.
Yeah, you know, I think a good piece to that too is, you know, you're exactly right. So that tear that, you know, is just, it's a flap tear, and what you know, the mechanical piece to it, right? So when you're bending, and this is kind of what I tell patients, you know, because we've got a CrossFit next door, and you know, a lot of patients are new to working out that come to see us, especially with knee pain, is that I just say, don't bend your knees past 90 degrees when you're doing a squat, right?
Yeah.
You know, can you talk about that a little bit? Like, what sort of advice you're giving folks that do have a diagnosed meniscus tear?
Yeah. So if they have a tear and we're going to try to do the non-operative route, avoiding deep knee flexion, especially weight-bearing knee flexion where you're going into a squat or a crouch, that's going to really aggravate the tear. It can even make the tear worse. You can make a tear further torn. You know, you can extend the lesion. So I think you got to be really careful about, as you get past 90 with weight, that's a dangerous position for the knee. It's a high stress position for the knee. And so, you definitely got to watch out for that. And I have that conversation with patients sometimes.
So let's talk about too. So another key kind of, diagnosis of kind of that 20 to 40-year-old, maybe runner or kind of like weekend warrior, is sort of that chondromalacia patella, right? So let's talk about that a little bit, and that'll kind of dive us right into the hemi knees and the total knees. Talk to us a little bit about that and what that patient looks like.
Yep. Yeah. So patellofemoral chondromalacia is really common. We see it in patients that are younger a lot. The cartilage under the kneecap is probably an area where we see the most early degenerative changes in people, and it's very common, especially in women. It has to do with sort of knee alignment in the female knee. There's sort of some alignment issues that can predispose women to getting this a little earlier than most guys, although guys can get it too. And what can happen is that cartilage over time rubbing against itself, or the kneecap rubbing in its groove, is going to start to wear down some of that cartilage. And if the kneecap is a little out of alignment from its groove, it's going to increase the stress in certain particular areas of that knee. And so if you put all the stress on the outside half of the kneecap and it's really rubbing hard because of a tight IT band or tight lateral structures, that will tend to keep the kneecap out of alignment and put a lot of stress on that cartilage. Well, a lot of times we see this start as teenagers, you know, that like 13, 14-year-olds will come in with anterior knee pain, especially young female athletes. MRI is totally normal. The pain is mostly present with running or stairs or, you know, hills and things like that. And, you know, we diagnose them with patellofemoral malalignment or patellofemoral syndrome. The cartilage looks normal when you're 14, 15. You fast forward that person when they're 30, over the years, that cartilage has started to get roughened and worn down a little bit from that malalignment. And so you can start to get some inflammation that results with that. The cartilage protects are the bone underneath. The bone doesn't like it if there's not a good cushion. It then sets off this chain of inflammation in your knee that can cause a lot of pain. And so the cartilage is like, I sometimes say it's like the enamel on your teeth. Once it goes, it's not coming back. There's no way to regrow it really. And we can talk about that a little bit. There are some ways to kind of regrow it, and there's some ways that we kind of work around that. But for the most part, wearing away of the cartilage is going to be a process that we can't reverse. And so once that kind of starts, you have to try to figure out ways to get the knee to feel better. In other ways, you can't do it just by regrowing cartilage.
What is your advice to those, the parents of those 14, 15-year-olds, as they age?
Yeah. So it's really important to identify this issue early on and work on the ways to keep the knee in good alignment. So a lot of times physical therapy is the key to that. And so we often will hook them up with therapy, early on to work on loosening and stretching the lateral structures around the knee, strengthening the VMO, the quad muscles to kind of win that tug of war over the kneecap, and try to realign the kneecap in its groove, and working on the hip especially, and looking at things like arch of your foot and how your foot steps and how the alignment of your foot and ankle then lead to internal rotation of the hip and malalignment at the kneecap. So the ankle, knee, and hip are all aligned, and they're all part of that kind of process. They all go kind of hand in hand. And there's sort of the classic, sort of in-toeing kind of valgus kind of heel foot, a bad patellar alignment, and weak hips that all kind of go together. I'm sure you see this all the time. But I think it's identifying it and addressing it early is key.
Yeah, there's a sort of I say she's a famous PT, but there's a book of sort of like PT diagnosis, and her name is Shirley Sauerman, and she talks about a lower extremity medial rotation syndrome, and it starts with the foot, and as that foot pronates and collapses, the subtalar joint, or the ankle joint for people, not non-medical people, collapses. Everything, the foot and arch collapses, and everything turns in. And when they turn in, there's a lot of stress on the inside of the joint, on the inside of the knee, and then the same thing on the inside of the hip and where the labrum is. And it actually throws you into lumbar extension too, the whole movement. And that's why it's so important to find somebody, that's in your area that knows how to really look from head to toe, right? And not just at a knee joint, poke around a little bit. You need somebody who's going to look at the foot, look at the knee, look at the hip, and understand how everything works together. So maybe that's an orthotic. Maybe that's, in combination with core, hip, knee, and ankle stability and strength. That's, typically when I treat a knee and it's a young athlete, I'm barely doing any knee exercise. A lot of it's core, a lot of it's hip, and a lot of it's balance, and I'm releasing IT, whatever's tight, posterior chain IT band, the back of the legs, and even the plantar fascia. It's all going to roll. But I think that's a great point. Work in conjunction with a PT at that age, because they're so young and they're malleable. They've got room to grow, right? I mean, they've got space. Like at 50, you've lived with that knee and you've done nothing about it. Now you're, so let's talk about that, right? So now you're 50 years old, you've lived an active life, maybe you've had, and again, we can kind of, so much we could talk about, but the female athlete, right? So that female athlete, in 1970 or 1980 even, who wasn't properly diagnosed or didn't even know kind of the options that we have today. Let's talk about that 50-year-old runner, right? And what their knees potentially look like, and what you're thinking in terms of total knee, hemi knee, and that sort of thing.
Yeah, so a lot of it's determined by X-rays and sort of looking at alignment on films. So when we start to get arthritis early on in the story, and I think maybe knee replacement, partial and total, we can get to maybe as sort of a little bit later in the chain of events, because there's a bunch of things we can do for arthritis before that, but I think we should talk about that too. So if we're starting to get arthritis, people get into their 50s, maybe 60s, still very active, and people are staying active much later in life. I see people in their 70s that are runners and very active, but certainly people in their 50s and 60s. If you're starting to get arthritis and you're an active person, or even if you're not active, but maybe you once were. So what do we do with that? So a a lot of it will depend on the degree of arthritis. So the cartilage, arthritis is the wearing down of cartilage in the knee. And so a lot of people think of arthritis as something that's growing on the bones or growing in the joint, like barnacles or something like that. But it's really not. It's the wearing away of the cartilage and the resulting inflammation that happens because of that. And so if the arthritis is severe, if it's bone on bone, we can try some things right off the bat. Although, when it's down to bone, we're going to be talking about knee replacement probably sooner than later.
Yep.
And the pattern of cartilage loss will determine what kind of knee replacement we do. If it's not bone on bone, it's kind of early, and if the joint space is getting narrow, the cartilage is thinned out, but it's not completely gone. Maybe you start to have a little bone spur there as a signal of some arthritis, a little stress on the bone. That's when we talk about things like injections. Cortisone is one of those, probably most commonly used. We use a lot of cortisone for those early to moderate arthritis patients. And basically what cortisone is just a really strong anti-inflammatory. It's a steroid. It works locally in the joint. It doesn't have too much of an effect on the rest of the body, although it can elevate blood sugar in diabetic patients if they have kind of hard to control diabetes. But in the vast majority of patients, it's very safe. There's been some bad press about cortisone over the last 5 years or so. There's been a few isolated studies that have said, yeah, there are some risks with cortisone. There's risks of things like further damage to the joint, stuff like that. Generally speaking, I reassure my patients by saying, we're not doing cortisone in a completely normal joint. If your joint is totally healthy, normal cartilage, we're not doing cortisone. It's not appropriate. So we're doing cortisone injections in patients where the cartilage is already damaged. The joint is already in trouble. And so this is a way to try to get your knee to feel less inflamed and allow you to be more active and stay in good shape for longer, and so it's not really a Band-Aid. Guys don't want to do it sometimes because they say, well, it's just a Band-Aid. Why don't we just go to get my knee replaced? That's the ultimate solution. But it really gets to the root of inflammation. And if you're not really bone on bone, then you probably shouldn't be getting a knee replacement anyway. So you don't want to jump to a knee replacement surgery before you're really ready for it. And so cortisone can be a great tool. I find it to be very helpful. And there are definitely people that don't respond to it. People, you put the cortisone in, it doesn't really do much. Maybe it helps for 3 days. When that happens, there's lots of other choices. And so, there's things like visco supplements, these gel injections that we use, Synvisc. There's like a half a dozen different brands, Euflexa, Hyalgan, Gelson, Synvisc.
Yep.
And those can be helpful for some patients too. They're kind of a lubricating gel that goes in and kind of lubricates the surfaces in there. And I have many patients where the cortisone has failed. Those seem to have helped. But again, not for everybody.
And you usually start with cortisone and then, are you picking a compartment, Phil? Like, are you saying, okay, I'm going to go medially, I'm going to go laterally, or just where arthritis?
No, I've heard of guys doing that, but the knee is all one compartment. Okay. We think of it functionally as different compartments, and the cartilage responds in different ways: medial compartment cartilage, lateral compartment, patellofemoral. Mm-hmm. But I shouldn't say it's all one compartment. 3 compartments, one space. Right. And so it doesn't really matter how you get the medicine in. If you go through the front door, the side door, the upstairs window, the medicine's all going to get into the joint, and it's going to flow around the entire joint and get in everywhere it needs to go.
Wonderful.
So that's a good question.
Yeah, because that's something we get a lot from patients, right? Is, when do I go get that cortisone shot? And, for me, and you can correct me, I'm not sure, what but people typically, I'm sure when they see you, they're in a lot of pain.
Yeah.
Same thing with me. They're still in pain, but they, sometimes we're fighting through it. And, when I educate even my younger staff, when should I send this person back to Dr. Lahey to get a cortisone shot? Typically for me, it's the pain. You're in 7, 8 out of 10 pain. You can't do anything. Like, go get a shot. It's not going to be the worst thing in the world. Right. That's usually the 50 plus. Yeah, I'd say 40, 45 plus. Now let's talk about, I know we're kind of jumping back and forth with age ranges, but cortisone shots in younger individuals in the knee. We can talk about the shoulder. Again,
shoulder's a little different. Yeah, shoulder's a little different because it's not necessarily in the joint. When we're putting cortisone into a joint, we do want to be somewhat careful. I think in younger patients, it's rare. I have done it in a few situations where people have had patellofemoral chondromalacia really flared up, swollen knee, and very, very painful. We'll sometimes do some cortisone. Generally, it's a one time, maybe two times total kind of thing. A lot of times we'll do it just as sort of as a diagnostic tool more than anything else. We'll do it sort of to see if it helps you. And if it does, we know that the pain is coming from that area and that it's not something else. If the pain comes back, if it works well, and then the pain comes back, I think then often in younger patients, I'm moving on to the gel injections, the visco supplements much quicker because I think they're safer for the joint long term.
Talk about some of the risks to the joint of the cortisone for like a younger individual.
Yeah, there's some studies that show like repeated cortisone injections over a long amount of time. So if you're 25 or 30 and you're having knee problems at that age, we can't do cortisone every 6 months for 20 years. That's too much. So what happens is that the cartilage cells, and some of it may actually be related to the marcaine or the lidocaine that we use, the numbing medicine, at the same time as the cortisone. It may not actually be the cortisone itself. It might be the numbing medicine that goes in with it. That is toxic to the cartilage cells. And so if you give the cells enough time to recover, 3 months plus for most people, it is safe to do here and there. But if you keep doing it over and over again, and especially if you do it in rapid succession, like every month or every couple weeks for a little while, it's not good for the cartilage cells. And you can lead to some additional cartilage damage if you're not careful.
So I feel like that's kind of where it gets sticky, like the pro athlete type situation or that college athlete trying to get to the meet, and I think that's where, as a physician, you kind of got to look at every situation individually. Like, let's say, you got, let's just use Edelman as an example, right? So we had knee problems. He's trying to eke out one more season. It's like, he's going to need a total knee at some point, I'm sure.
Right. So it's a little different in professional athletes, because if you have millions of dollars on the line as the athlete and you say, I don't care if I need a knee replacement in 5 years or 2 years or even 1 year, I need to get through this season because I need to get this contract and there's millions on the line. I think, you have to weigh the costs and benefits, and somebody like that, you might say, okay, the benefit may outweigh the risks. And for an everyday, more average person like me, I mean, I would say no way, it's not worth it. But yeah, so those are the kind of the issues that come into play in sports medicine that are unique. And it's similar to sometimes, a senior in college heading into their final spring season in a sport. They've got some issues, patellofemoral chondromalacia or something like that. They just want to get through the last 3 months of their senior year in order to finish out their college career. Beyond that, they're not going to play lacrosse professionally or whatever. And they know that they want to be active, but they're done with the sport after 3 months. That's a situation where maybe you'd have a conversation about, well, it might be possible, might be appropriate.
Yeah, I think that's great. Let's talk a little bit about the Synvisc and those sort of, I call it, it's almost like just a layer of like pseudo cartilage, right? Let's talk about what the client outcomes are with that, and how long people should experience relief.
Okay, yeah, good question. So first of all, there's like maybe a dozen different brands out there. They're all about the same. There's never been a big study to show that any one particular brand is better than the other. So whether it's Hyalgan, Synvisc, Orthovisc, Euflexa, there's a million of them, it doesn't matter. They all have slightly different characteristics, but I think it's probably a moot point. What it really is at its most fundamental is hyaluronic acid, which is the molecule that makes up cartilage. So it's a very safe thing to put into the joint because it's the same molecule that's already in there. You're not putting any sort of medication in there or some sort of a chemical that's going to disrupt the cartilage cells. And what it does when it goes in is it doesn't really replace the cartilage. I think it really works more like a lubrication of the cartilage. It may provide a little bit of a hydraulic cushion while it's in there, but it's not in there forever. And it does kind of get processed through the body, and the body probably absorbs it over the course of a couple months. It can often last for 3, 4, 5, 6 months at a time. And I have had many patients that have had it last longer than 6 months, the effects. And so generally speaking, insurance, we most often will get insurance to cover it, and then we order it in the mail. So it does take a couple weeks to get in. And then we start it, and it's a series of 3 shots for most formulations. There's a couple formulations for just a single shot, but we usually try to break it up into 3 shots once a week for 3 weeks in a row. And after the 3 weeks, we say, hey, let's see how this works for you. And sorry. If my phone disconnects, we're going to have some problems, but I think it'll be okay. So we'll see how it goes. And so often patients will have some good relief from the pain and the inflammation that they've been having for many months at a time, especially in early to moderate arthritis. If it's really end stage arthritis, totally bone on bone, it rarely works well. I can't say never, but doesn't usually work well. But for the people who still have some cartilage there, I think it really does help. It also seems to have some anti-inflammatory effects, which we don't totally understand. We think it may change out the joint fluid a little bit. So instead of all those inflammatory cytokines, it kind of changes out that joint fluid and seems to get the whole knee to be less inflamed.
Nice, almost like an oil change for the knee.
Yeah, exactly. Yep.
That's interesting. So does your body absorb kind of the cytokines and that sort of thing? Is that how it would just kind of?
Yeah. Those get broken down and absorbed. And if you break that inflammatory cycle, your body will reprocess all that stuff. And you're constantly making joint fluid. And so if the joint is less inflamed, the new joint fluid that's coming in and produced is less full of those kind of inflammatory chemicals.
So does it kind of mix with the synovial fluid? Is that what it?
Yes. Yep.
Let's talk about, so I know, and it's been described to me, and there's a lot of cartilage breakdown. I've never, been inside of a knee, right? But can you talk about what it kind of looks like, like a rocky road or something like that? Like, what does that chondromalacia patella look like, and what does it look like?
Yeah. Oh, yeah. I should have brought some pictures or something to show you, because I have been inside of a knee. So yeah, it's so cartilage is that kind of smooth stuff. If you think about the end of a chicken bone, that kind of smooth whitish stuff on the end. And when we're young, it's really smooth, firm stuff, and it's hard to kind of, damage. Really, it's very, very durable. As we get older, it dries out a little bit. It starts to flake, and so the first things you see are these kind of flaky fronds that start to kind of lift off the surface, and then over time, it starts to wear thin. Those fronds go away. The actual cartilage starts to kind of break up, and you start to get patches that are kind of chunks missing. And it's usually in the weight-bearing portions of the joint. So on the femoral condyle, and so the round part of the end of the femur, under the kneecap is a classic area. And so eventually those chunks start to kind of coalesce, and you start to get sections where there's no cartilage left at all, and you start to see the bone underneath. And so you start to get the sort of yellowy kind of bone surface, subchondral bone, that you start to see. And that's when you start to really feel that grinding and clicking and stuff like that when patients have arthritis.
Now let's talk about the pain, right? So pain associated with because my knees both, they both click, right? Or they not click, but they grind, positive.
Yeah.
But I don't have pain, right? So talk through, the neural end of it, and how, like, if you get into a joint, you're like, oh my God, this is really bad. Like, what are you looking at?
Yeah. So, I mean, some of it's a little bit unpredictable, but because some people have knee pain in knees that don't look that bad, and you get inside and you're like, geez, I'm surprised they're having this much pain. So everybody's a little bit different. The clicking and grinding that you get under your kneecap in the front of the knee that's non-painful is probably early chondromalacia. The surfaces are no longer totally smooth, but with just gentle range of motion, they're just gliding past each other, so it's sort of 2 rough surfaces that are rubbing against each other. As you start to get that kind of roughening on the weight-bearing surfaces, and you start to get that real pressing down on that cartilage surface, and that cushion really isn't there, the bone underneath is sensitive. And so it's going to start to cause inflammation. It's going to be painful if you step on an exposed piece of the bone where it's not covered by cartilage anymore. And then there's the soreness that you get just from swelling. So the bone responds, the joint responds to that by causing swelling. The swelling makes the knee sore too. So everybody's a little different. Pain is sort of a uniquely experienced kind of thing. But but that's pretty reliably going to be uncomfortable when you get that weight-bearing surface affected.
And so that we talked to, talk about this a little bit, but just weight gain and knee pain, I think that there's definitely a direct correlation between adiposity and,
Yeah.
and knee pain.
Yeah. Unfortunately it's a big issue these days. It has been for decades really, but weight gain is a part of it. So people definitely who put on weight notice their knees feel worse. And on the flip side of that, there's been some good studies to show that even losing 5 or 10 pounds can make your knees feel better. Maybe not completely pain-free, but it takes some of the weight off your knees. And so, I always encourage patients to patients with early to moderate arthritis, if it's possible to lose weight, it's part of the whole picture of treatment. It's tough, but
and it's tough to coach too, right? Because it's really the holistic piece that I think, in my office and in your office, we're focused, it's probably a little bit easier for me to maybe say, hey, listen, I know a great nutritionist, Val, just at least consult with her and just have her, but I can't, when I have an hour and a half with somebody, I can't talk about, what to eat for dinner. It's just not, I need that hour to fix your knee, so like, I think when we talk about the whole person and looking head to toe, working in, a nutritionist in that sort of capacity might be helpful.
So in orthopedics, we are admittedly not great at treating the whole person. We're very good at treating a specific injury or a diagnosis like arthritis. You have an hour and a half. I have 15 minutes, so per patient. And so we have a very limited focus. And if we're laser focused on stuff, we can treat things effectively. But we miss the big picture a lot. And I think that's where primary care can come in, certainly. And you guys can be a part of that puzzle too. But seeing a nutritionist and that can be a big part of this for sure.
Yeah. So let's talk about those operations. So what do you most commonly feel like? What is your kind of like, who are you seeing most? Who is that patient you're seeing for knee pain most often? And what's the most common procedure you do?
I would say the most common thing that I do is our knee arthroscopy surgeries for meniscus tears. So that's more common than probably knee replacement. Typically people in their 40s and 50s, sometimes 60s, but people who are really doing normal things most of the time, I would say 60% of the time, probably normal activities. They crouch down to pick up something off the floor. They feel a little crunch in their knee, or they're outside and they step on a bump in the yard and they just kind of feel something tweak in the knee. Sometimes people don't have a good injury story at all, but they know at some point in the last week, it just suddenly got a lot worse. And it was probably something they've done a million times, but it just happened to catch the meniscus in the wrong way and tear the cartilage. And that, we get an MRI, we take a look, we see the cartilage is torn, and then we start talking about, usually knee arthroscopy at that point. Knee scopes, great surgery. It's a short, 15 to 20 minutes of actual surgery, day surgery for sure. And you're probably only at the facility, whether it's a hospital or a surgery center, for about a couple hours. 2 tiny incisions about the size of a centimeter, maybe less than an inch in the front of the knee. We look inside with a camera. We look around the whole joint, take pictures of everything to kind of document all the cartilage, the surface cartilage under the kneecap, all these things that we've been talking about. And then for the meniscus tear, we look for that and then take out the torn piece, leaving behind as much good meniscus as we can. And that's pretty much it. Then we're out, a couple stitches, and we're off and running. I don't restrict weight bearing. I give people crutches, but honestly, I think most of my patients may use crutches for a day or two. You're allowed to put weight on it immediately. Total recovery time is kind of like 3 to 6 weeks before you get back to everything, but you're allowed to put weight on. I tell people the first week, really ice and elevate a ton. Take the rest of the week off from work. People shouldn't be going back to a physical job for at least a couple, maybe 3-4 weeks. Desk job might be a week, back to work, but a lot of people are feeling a lot better at 2-3 weeks.
Yeah, I found, even with many scopes, they're so well done nowadays, and maybe you can talk about the difference maybe in tools too in the last 10 years. I was finding 10 years ago when I first started that I would see, knee scopes for probably 6 to 8 weeks for PT, and now I feel like it's maybe 4 to 6 weeks, if at all.
Yeah. Yeah. I mean, I have many patients that come in at 2 weeks and they say, my range of motion is really back. I feel like I get running again, and I let them just do it on their own. I'd say 60% of my patients I send to physical therapy for at least a few weeks. Yeah. 3, 4 weeks, maybe 5.
You know,
I don't know. I don't know why it's shorter now. I mean, maybe that's a better question for my father. Why his patients took so long 20 years ago, but
we better get a put for that one. But
yeah.
I think too, Phil, I think it depends like how the patient presented prior to, if somebody who's, been with, they're going to have VMO atrophy, if they've for a long time, they're going to have, if they've had inflammation, that's somebody who's going to benefit from really probably pre-op and post-op. But, I think that the atrophy piece and how long they've suffered probably plays into it. But if if you're walking the backyard and you kind of, or even on the golf course, you kind of twist it a little bit and then it, flames up, that's probably not, and it's just been a couple weeks and it's a month overall, probably not somebody.
No, yeah, not it's the patients we are going to do that surgery on are usually people who have been struggling with it for a while. They gave it a chance. It might have, so a lot of times the pattern is like, it's really bad for a week or two, then it settles down, and then it kind of plateaus. And where it plateaus is what determines whether or not we need to do surgery. If it plateaus and it's like pretty good, you might feel it a little bit. That's fine. You don't need surgery for that. But if it settles down, but it plateaus at a place where you're like, I can't do anything. I can't exercise. I can't get back to playing golf. And it's been like a couple months. That's when we're probably going to be doing surgery.
So let's talk about this. So my uncle literally calls me yesterday. He says, Sean, went to go see my orthopedic, or maybe it was a primary care. And they said, looks like you got a meniscus tear. Here's a brace. You're good. So what is your thought on bracing and its role in meniscus tears and knee pain in general?
I don't find that there's really a role for bracing with meniscus tears, really at all. I mean, I think it's always okay to try like an over-the-counter CVS or Walgreens compression sleeve, the little cutout for the kneecap, and it's got like a Tommy Copper thing. Tommy Copper's too expensive, but just something you get at CVS to give you a little compression, maybe help control swelling, give you a little of that proprioception. But I mean, really, a real brace is for replacing or augmenting stability for a torn ligament. Or if you've got an unstable knee, you're going to need a brace to kind of support the knee. The meniscus is a structure on the inside that's a cushion. So the brace isn't going to do anything for that. So I'm kind of anti-brace for meniscus tears, unless you want to try like a little sleeve on your own.
Yeah, I mean, I'm straight anti-brace too on that, because it's going to turn off the muscles from acting too, because a brace is a passive support, right? And I feel like it's definitely not a solution, but I asked him if it had metal in it. That's another piece too. So is it? I didn't do his exam. Maybe he has a little medial. Maybe he's got a little bit of laxity in there too. But 50 years old, I don't want you just put on a brace. Let's do it. And I think the pathway needs to be strength, mobility. See if that helps up, unless there's a diagnosed, real, nasty meniscus tear.
Right.
But I think that's a big thing too, Phil, is that people need to know they have the option to go to you and just get it done, a scope done.
Oh yeah. I mean, there's no need if you're really suffering with a meniscus tear and it's painful all day long or consistently with certain activities that you need to get done. This is a very treatable injury that really people do typically very well with. And I mean, really, there's always exceptions. Some people, there's complications sometimes, but those are rare. This is a very safe surgery, low complication rate, really low, tiny incisions, fast recovery time. I mean, it's a good surgery and it helps a lot of people. So there's no need to suffer. And really, I respect that. I mean, our primary care colleagues are phenomenal, and they are fundamentally important in this whole team approach. But there's nothing wrong with seeing an orthopedic guy if you have a problem with the joint. And so if your knee is bothering you, it might be time to see an orthopedic guy.
Yeah, and just go. You can go straight there, especially if you got a PPO. PPO.
Yeah.
Let's talk about kind of the advanced aging knee, right? So the quad tendon repairs, that sort of thing. And then, we just touched on that for a second. Do you do many quad tendon repairs, Phil?
Sure. Yeah, absolutely. I mean, those are more like, we see a few of those every winter from slips and falls on ice and things like that, but they can happen with any kind of activity. Sometimes we see it more because people are staying active so much longer in life, we see it more with guys in their 50s and 60s playing softball or basketball or racquetball, and their quad tendon will rupture. And it's a pretty common injury. It can be pretty devastating to the knee. We can get them back, but it's a long haul. And the knee often is never exactly the same after a quad tendon rupture. I mean, that's a massive muscle group to just have suddenly disconnect. So, but it's repairable, and we treat it like an acute injury. People know typically right away when it happens. And once we are able to see a patient with that, the diagnosis is pretty quick, and we're going to want to repair it quickly. Usually within a couple weeks of the injury, we're going to try to sew that back down to the kneecap, bring that tendon back down, sew it into place, and start the healing process.
So how do you do that? Because that's going to be a pretty thick tendon, huh? So are you anchored?
Not anchors, actually. So what we often do is we do some whip stitches. So we suture really heavy, thick cord into the tendon. And so there's usually 4 strands that come out. So kind of up and down and 4 strands. And then we drill 3 tunnels through the kneecap. So very narrow tunnels, usually with a small drill bit, through the kneecap. We bring the sutures down through the kneecap and then tie them on the bottom. So kind of over a bony bridge. And so you have the tendon comes right back down and attaches onto the kneecap itself.
Nice. Now, how long do you feel like that takes to really take?
So we protect the flexion. We sort of limit flexion and protect the knee for a good 6 weeks. And during that time, we don't really want to bend the knee much past, say, 30, 45 degrees. And then after 6 weeks, we start to kind of regain range of motion, because at that point we feel like the healing has probably occurred and it's safer to start to flex the knee more and try to get back your range of motion. And then that's where the challenges sometimes occur, is that 6 to 12 week to 16 week kind of time frame where you guys are working on the range of motion, and it can be tough sometimes.
I think, like smokers, right? You immediately double that rehab time. That's kind of the way that I look at it.
Yep.
That's always kind of a weird variable. Are there any other variables that you're thinking, like when you see somebody, who's partial weight bearing, not even for a quad tendon repair, but any sort of knee repair? Anything else?
Yeah, I mean, patella tendon repairs are very similar. They often rupture too, and act. They sort of are a similar rehab and similar surgery. Yeah, smoking is one of the big ones. Diabetic patients have some interesting issues sometimes, higher risk for infection. The healing rates for diabetic patients can be a little bit lower. So smoking and diabetes are the 2 things that we really think about a lot. Yeah, I always tell my patients who smoke, like, literally every drag you take on the cigarette, the blood vessels constrict, and that limits the healing. So even if you can just cut back a little bit, anything helps. Like, you don't need to go cold turkey and quit smoking like for the first time in your life. Any amount of cutting back can help. And so I try to really encourage patients to do that.
Especially, pre-op and post-op. But
oh yeah.
Let's talk about total knees.
Yeah, absolutely. So knee replacement, certainly is a big part of my practice. And when I first started, it was all total knee replacement. I didn't do any partial knees. We'll talk about partial knees in a minute, but total knee replacement is a big surgery. I always tell my patients, don't take it lightly. Some guys will want to come in. They've had knee pain for 6 months. They have some arthritis on the x-rays, but they haven't really tried anything else, including they don't like Advil. They're not a pill person. I don't like Advil. But that's not a time to do a knee replacement. Time to do a knee replacement is when you've tried everything else. Maybe physical therapy, possibly bracing, certainly injections, and nothing else has worked. And you're having daily pain that's affecting your ability to do the things you want to do. Not necessarily affecting everything you have to do, but if you want to be more active, if you want to go out for walks more often, if you find that interacting with your younger family members is difficult, if you're avoiding going to the store, those kind of things, that's a signal that let's try to get you feeling better with a knee replacement, because we want you to stay active. We want people to keep moving. That's the most important thing, is keep moving. Once you shut it down and you say, all right, I'm not going to go to the store anymore, I'm not going to hang out with my family, I'm not going to go for walks, the whole body starts to become problematic. You get back pain and your hips get sore and everything gets bad. So, and you see this all the time, I'm sure.
Yeah.
But yeah, so the knee replacement. So what a knee replacement is basically we go in and we trim away all the joint surfaces, and then cement onto the bone metal components that kind of cover the bone. That goes for the end of the femur, the thigh bone, and at the top of your shin bone, the tibia. And then we put a plastic spacer in between. And so it's a very smooth metal on plastic articulation, and it's basically replaces the entire joint. I typically also replace the undersurface of the kneecap. Some guys, especially in Europe, they don't do that. And there's some movement here in the United States to kind of avoid that, but I typically replace the kneecap as well.
Do you find that the undersurface of the kneecap, is it typically the trochlear, is it the groove that's deteriorated, or is it both? Like underneath the kneecap and the
I would say it's both. And I can say from my experience with arthroscopy, we definitely see it in both places. It can be a little different. I would say the lateral facet of the patella is very common, and the trochlear groove can be an area where there's some problems.
Yeah, so now is that if you're replacing the underneath of the patella, and that's metal, and then there's metal, I'm assuming, on the condyle?
So actually the undersurface of the kneecap is replaced by a plastic dome. And so that's a plastic piece that goes on the metal femoral component. So it's all metal to plastic. There should be no metal touching metal.
Nice. And then this plastic is the spacer in between, right?
Yep.
Now, and this is going to be an aside, but so I've seen knees that literally just maybe infected. This is more like at the hospital, and I worked at the hospital, but that was just a spacer. Have you ever seen it? Have you done anything like that? Or yeah,
like a cement spacer?
It was either a plastic, I'm not sure what kind of spacer. It just said this person doesn't have a total joint. It's because it was.
Yeah. So yes, that is typically what's done when you have an infected implant. So one of the things we worry about enormously for knee replacement is infections. And so if an infection gets deep and it gets onto the metal or the plastic, our body doesn't have the ability to fight off the bacteria once it gets onto the metal, because the metal doesn't have a blood supply. There's no way to get the white blood cells onto the metal. And so it just grows like crazy. And then if you do get a deep infection into the implant, we got to take the implant out completely and then put in an antibiotic spacer for a period of time so we can clear the infection. No. And fortunately, that's rare. And I think you see it more with more complicated patients with more medical issues. It can happen a little bit more often. But thank goodness it's typically quite rare, but it is one of the more dreaded complications for us, because it makes for a much more complicated course, and it's tough on the patient for sure.
Yeah, I always remember reading those charts, and I'm like, do I walk with this person or get them?
No, yeah.
We're not doing much for a little bit with that person. But let's talk about. So I think somebody who's thinking about getting a total knee, right? So some people are afraid, and this is what I hear in my clinic. They're afraid, they're nervous, they don't want to have a big operation, but they're in a lot of pain, and I'm kind of coaching them. Hey, listen, we're doing everything we can in here. And I kind of know, I've been doing this for a while. I know when people are going to get to the point where they can't do another scope, or they can't do a scope. They're 60, 65 years old. Scope's not going to do anything. It's really, so what in your brain, like, who's that perfect person for the total knee?
Yeah. So a lot of people are looking for like shorter, quicker fixes, like a scope. The days of doing arthroscopy for arthritis are over. That was a big thing in the late 90s and even early 2000s, but a bunch of studies showed that was not helpful. And so that a lot of guys will say, yeah, I had a scope and they cleaned out the arthritis. There's no such thing. It was shorthand for whatever they were doing back then, but you can't clean it out because it's just the cartilage isn't there. So the scope isn't an option in those patients. I think I tell patients that, well, first of all, I never want to pressure a patient to do a big surgery like that. I think that would be wrong. And if a patient talks to a surgeon, they're like putting a lot of pressure to do the surgery, you got to do it now or something like that. That's not a great way to handle that situation. I think I would say most patients are going to know when they're ready. And it really has to be a patient-driven decision. And they're going to say, I tell my patients all the time, you're going to probably tell me when you're ready before I tell you. And so if you've tried other things, if you've done all those other treatments that we've talked about, medicines, injections, bracing, physical therapy, and it's a daily problem for you that's causing a disruption to your life, and you're in a lot of pain and it's preventing you from doing the things you want to do, then I think that it's totally reasonable to do the surgery at that point. But you also have to be sort of mentally ready to work hard in physical therapy and be able to put up with a little bit of pain at the beginning, and probably more than just a little. The first couple weeks are quite sore. It's not fun. Now we can manage pain pretty successfully with some pain medicine, not excessive amounts, but enough pain medicine to make it manageable. But as long as you get through those first couple rocky weeks, people really usually do very, very well, and the results are often very good. The other thing is, a lot of people will talk to their friends or family about it, and so they get a sample of 2 or 3 people, and one of the 3 people said it was great, but the other 2 said, well, it's been pretty tough, and that's it. That's their big study.
N of 3, yeah, that's pretty.
Yeah, cool. The N of 3 or N of 1. My friend had a knee replacement, he did terrible, so I'm not going to do it. And I would just caution people, everybody's different, and there are certainly some patients that don't do well, but really 90%, approximately 90% of patients in most big studies are happy that they did it. And while that does leave 5% of patients that have some sort of complication, and maybe another 5% that there was no complication, they just weren't really happy with the results. Either some residual pain or some stiffness. I think the vast majority of people are very happy with the result.
What should people expect other than pain, in the first few weeks after a total knee?
Yeah, so early on, most patients are going to be doing physical therapy at home while they can't really get out as easily. And so for the first week or so, we do a lot of in-home therapy. And that's especially now these days much more common. We used to send a lot of patients to rehab, rehab facility, skilled nursing facility. Almost, I'll say nobody, but very few patients are going to skilled nursing facilities or rehab facilities after the surgery. Most people are going home with visiting nurses and therapists coming to the house. So it's a much more comfortable experience for most people. And so they're going to be working hard to kind of start to bend the knee more and try to get it straight. And so while the therapist is working on it, it's going to be somewhat swollen and it's going to be sore. The incision heals up usually pretty nicely, but that's a concern in the first few days, week. And so basically the therapist is going to start to kind of try to bend and extend the knee. That's the big thing, is just getting the motion back early on. And so once we get the motion back a little later, and especially as they transition to outpatient therapy, that's when you really start to work on strengthening. And so I tell patients a lot of time, the first 6 weeks or so, working on the range of motion, second 6 weeks, working on strengthening. And so by 10 to 12 weeks out, people are getting back feeling like, close to 3 months, they're getting back to most of their normal activities pretty comfortably. It's probably more like 6 months before it really feels like your knee and you're just not thinking about it anymore.
Yeah, I think that's great. It's great for people to know, Phil, because I think a lot of people with that fear, they just keep putting it off. But, I think they know going into it, it's going to be 3 weeks of pain, really 6 to 8 weeks, is what I tell people. But
yeah.
And then after that,
it gets better and better as you go along.
I think is if people kind of can hear this talk and can learn that and understand that, and the total knee is the right choice for them, I think that kind of helps alleviate some of that fear of going on and the complications and everything else, DVT, whatever else it might be. What exactly are you looking for from PT for that first few weeks in terms of 0 degrees extension, flexion? What are you looking at?
Yeah, so trying to get out to full extension is really important early on. Many people have a little bit of a hard time getting that last 5 degrees before their first postoperative appointment with me, which is usually about 2 weeks after the surgery. I'll see patients 2.5 weeks. So if we can get out as straight as you can, so that if you don't get the extension early on, it's very hard to get it later. And so it's really important to work hard in the first few weeks to kind of get that leg straight. For the bending, we hoped at about 2 weeks that people can get to about 90 degrees. I have found that if you can get to 90 at 2 weeks, you're probably going to be able to get the rest of it back, usually another 30 degrees or so, because 120 is kind of the number that we sort of use as a goal most often. So that in another, over the course of the next 3 weeks or so, you get the last 30 degrees. And so that's the kind of rough range that we like to use. Now, if you go into the surgery with a stiff knee, you're gonna come out with a somewhat stiff knee. It's not like it's a totally new knee that you can move around, because all the soft tissues are the same. The ligamentous structures, the muscles are all still the same muscles. So if you go in and you haven't bent your knee past 90 in 10 years, you might get a little bit more. We often tell patients we probably will get another 10 degrees, but it won't go back to 120. I mean, so there's only so much we can do.
So that's an interesting point, right? So I talk to my therapist all the time. Is it joint or is it muscular, right? What's causing the lack of range of motion? And a lot of times it's both, right? But I think that's really interesting. If you need 90 degrees to go up and down stairs, right? So I think a lot of people, if they don't have that, they're in trouble. But
yes.
Do you use CPM?
We've gone away from CPM. Very early in my career, we were still using it. There was a few studies that came out saying that it didn't really improve people's range of motion much at longer term, out, like 6 weeks, 12 weeks, and certainly not at 6 months. And so a lot of insurances stopped paying for it. And so we basically have gone away from it and said, it's probably not necessary. If we can get patients in to see a therapist earlier, they tend to do better anyway. And so I think working with a human being usually works better than the machine.
Yeah. I think self-efficacy, especially in the early onset of it, is huge too. And just kind of getting if you can get good home care to come in, and it's always fine because, unfortunately the poor home care therapists don't have all the tools. They don't have an Ultra-G treadmill. They don't have all of the tools that we have to help train somebody. They don't have a full gym at their disposal. So usually they're traveling around with some TheraBand,
Yeah. So we kind of get through those first, that week or two, but I always tell my patients, you're going to make a little leap when you get out to the outpatient setting. It's motivating. You're out of the house. There's other people working hard around you. They have great equipment. So I encourage people to get out and go to outpatient PT as quickly as possible.
It's just so tough, Phil, because when I get somebody, I inherit a knee it's lacking 5 degrees extension, or, sometimes 7, 8, 9, 10. Like, what were you doing for the past 2 weeks? It just drives you nuts,
I know.
But so start sending them my way immediately.
Yeah.
When they're and I say it specifically because those 2 weeks are really, really important. If it's not their right knee, they should be able to drive. But even if you get somebody to drive you too, if you're young, and again, I mean, a lot of times people have they might have a nursing component to it too, that they medically can't come see an outpatient PT. So I don't mean that.
No, of course, yeah.
But I really feel like those first 2 weeks, it's important for people to understand. You can't just loaf around on your couch with a pillow underneath your knee just because it feels better. You need to get your knee into some extension, and that's the conversation. When I did home care, that was the conversation I'd have with my patients: is you got to put your leg, maybe prop it up on an ottoman and put something on it, for 10 minutes every couple hours, to get it and keep it straight.
That's the other thing. It's like the little bits all day long that are really important.
Consistency. So we talk about stretching, right? So it's for 1 minute every single day, right? So the creep takes place over a period of time. If they say that if you can stretch, and you might have different strategies yourself, but if you can stretch a muscle for a minute and you do it 7 days a week, the outcomes in terms of creep, that muscle creep, are going to be much, much better if you can do it than if you missed even 2 days. So it's consistency of it, especially for muscle length, that's so important. But anyways, that's a complete aside. But let's talk about the hemis, because I really haven't had a ton of luck with rehabbing them. I've had not many. I've maybe had 10 or 20 that we've done, or I've done personally over the course of my career, and they're foggy. That some do really well and some are just awful, like really bad.
That's interesting. So so I've had a great experience over the last 2.5 years doing partial knee replacement, and I only do medial partial knees. There are guys that will do lateral partial knees. So the most common compartment I see that's affected when it's by itself is the medial compartment. That's the inside half of the knee. There are other guys that will do patellofemoral partial knees with just replacing the patellofemoral joint. That gets a little specialized. There's total joint specialists that do kind of those more specialized type procedures. Guys that have a background in that training. I stick to the medial side of the joint, and I use a mobile bearing spacer. So instead of the plastic spacer being locked into place, my plastic spacer is movable. It kind of glides back and forth. And so I think that's a little change in the technology that I think has really changed the outcomes. It used to be 90s, early 2000s, the partial knees got a really bad rap because they went downhill quickly and people needed to convert to a total knee fast. And so it was like, why am I going to do a partial knee if I'm just going to need to do a total knee in 5 years? That doesn't make any sense. Let's just do the total knee. And so I didn't train in my residency training. I didn't train how to do partial knees. My father never did them, didn't believe in them. But I think it's because the results were bad back then. They didn't have good results. That changed in the early 2000s, kind of 2005, 2010 kind of range. They started to introduce these mobile bearing partial knee replacements, and the results are better. There's some good research. There was a TopCat study. That's the acronym, like total or partial knee arthroplasty something. And they looked at long-term outcomes. At 15 years, with the mobile bearing spacer partial knee replacement, the one they used was the Oxford knee replacement. They had 94% still going strong at 15 years. At 20 years, it was 91%. So basically, those numbers approach total knee replacement success levels. Total knees only last 15 to 20 years. So the results of these mobile bearing ones, I think, are better. And I think that the technology made a little leap in the 21st century. And I think due to that, I was more comfortable using them. And so my experience so far is that the range of motion is much easier to get back. So we're only replacing that inside part of the knee. We're not touching the kneecap, really. We're not touching the lateral side. You got to pick the right patient. So the patient selection is absolutely key. They have to have an intact ACL. The lateral structures have to be fine. The patella has to be mostly fine. If almost all the arthritis is isolated to that inside half of the knee, we replace that section. It seems like so the rates of complications are lower, needing blood transfusion way lower, blood clots, DVTs way lower, infection way lower. And so I have also found that just patients have an easier recovery. I've had patients playing golf at like 6 weeks, 8 weeks out after a partial knee replacement. I had a guy who played 18 holes 6 weeks off after surgery, and that's a little unusual. Not everybody's like that. I tell most of my patients it's probably about a 2-month recovery instead of 3. And the range of motion I have found to be dramatically easier to get back. Not universal, but whereas the total knee replacements, they struggle. It's the first few weeks, it's not easy. It's a real challenge. Most people are up to it and can do it. The partial knees for me mostly have been like, hey, at 2 weeks, I feel like I've got a lot of my range of motion back. At 6 weeks, it's back. I mean, it's for almost everybody. So yeah, I mean, I that's just my personal experience, and everybody, there's different brands of replacements out there. There's still some static implants that don't have that mobile bearing, static bearing. Could be, the individual patients too. Some patients are just sort of more ready to do that PT. Other patients are not quite as ready. But I've had some really great success with it. And if it's at all possible that a patient can get one or the other, I recommend the partial when I can. It's got to be the right patient, but when they can do a partial, the results are better, I think.
Well, I think that's, if people have it as an option, right? I think if you can go out and do the whole reason that people go get these surgeries to begin with is because they can't do what they love to do, right? So, right. And that's one piece too that we didn't really talk about. So in terms of the ACL, are you snipping the ACL during that total knee?
During a total knee, we do. Yeah. So you remove the ACL. That's pretty universal for most systems. The PCL is different, and we don't always take that. I leave the PCL in place when I can. We sometimes have to sacrifice it if the knee is too tight. But most of the time we try to leave the PCL in place. That's a little bit more, that's kind of 50-50. There's other surgeons who take it out automatically every time. But the design, what's that again?
Keeping the LCL and MCL?
Yes. Yeah. MCL, LCL, we leave in place almost always. Those are really important to kind of keep the side to side stability.
What keeps
I'm sorry, say that again.
What keeps the A to P stability, the front to back?
Yeah. So the PCL keeps that posterior stability intact if you keep it in place. If you don't have a PCL, if you have to sacrifice that, there's a special type of PCL implant that goes in and has a box in the middle and a little post on the plastic spacer that kind of locks into the box. And so it keeps it more stable that way. So there's design implications if you take the PCL out. So yeah.
Anteriorly dislocate like like on a tibia on a fibia?
So the balance, the balance in flexion is really, yeah. sorry, I'm talking over you. Yeah, so that's something that we look for and control during the surgery. So we are constantly kind of checking stability of the joint during the surgery, and if it feels loose, we actually have to increase the spacer in the knee replacement to kind of make it more solid and stable.
Yeah, no, that's great. What other questions do you think people would, if they're considering getting a total knee, what other questions do you commonly field? Just as we kind of wrap this up.
Yeah, good question. Yeah, it's good to be about that time. We've been talking for a while.
We haven't even touched ACL. We haven't touched half of the,
No. I mean, there's a lot. I mean, there's the whole sports medicine side of it, and then there's the arthritis side of it, and they're really kind of different, and there's a lot to talk about. But this has been great. We've touched on a lot of good things.
We'll have to have a part 2 about just the sports med piece, like the younger.
Yeah. I mean, that's ACL is like, we could do a whole talk on just ACL, but yeah. So questions that people come in, I mean, most of the time it's how long am I going to be out of work? How disruptive to my life is this going to be? How much help am I going to need in the first couple of weeks? And I think for physical jobs, I tell people it's going to be 3 months. If you have a construction type job, or if you're on your feet all day, every day, physical job, which, I probably say the majority of my patients come in with more physical type jobs. It's going to be probably 3 months before you get back to that. It's not that you can't get back to it, but it's probably going to be at least 3 months before you're doing any sort of extended time on your feet at work. Now, if you work at a desk job, I've had some people go back at 2 months or even 6 weeks, and they feel pretty good at that point if they can get in and out of the building easily, and the drive to work isn't a factor. Then some people get back to work at 6 weeks. But people need some help in the first couple of weeks, especially. It's good to have somebody staying with you. If you have a spouse or a adult child that can help you out, just kind of getting the simple things, around the house kind of set up, making sure you can have meals prepared for you if you need that in the first couple of days, even. It's definitely it's a big deal. But like I said, you get through those first few days, maybe a week, 2 weeks, and all of a sudden you're like, hey, I'm moving around a little bit better. We get people up and walking right away. I mean, the day of surgery, they're up and walking. So, it's not easy. You need help, but there's not a lot of time laying in bed,
Right. So there's, so your weight bearing is tolerated, so they can move around and
right away.
Get you right back up on that knee. So,
yep.
So let's wrap this up. I think I've kept you for almost an hour and a half. So with a little bit of technical things.
Yeah.
I feel like we could talk all day about this, but and all the other topics. But let's just kind of touch on a couple takeaways from today. And I think the first one that, at least for me, I took away was that if you've got a meniscus tear, you just really need to have a solid orthopedic consult to see really where that path should go. I really think that all meniscus tears, if they don't come through me first, should go through you. Because I think if you can fix somebody and provide them relief, within a month, that's a solid option. You don't have to suffer with a meniscus tear forever.
Right. That's true. I totally agree. I think, if you're having sharp pain, if the knee pain is really disruptive to what you want to do, it's time to see an orthopedic guy or girl.
Yes, exactly. And then, my second takeaway would be just, I think it's really important for people to understand that they do have the option to do a hemi-knee or hemi-knee, or if they're a candidate for it. And if they are, I think if you can go back to golf or whatever you love to do at a shorter timeline than a total, it sounds like the outcomes are unbelievable after 15 years. So, and 15 years is that's a good stint. That's not, 5 years or 10. It's like a pretty powerful study. What was the end in that study?
Oh, I mean, this was a huge study in the Lancet. They've had a couple different papers they produced from the study. The most recent ones were from 2019, 2020. Tens of thousands. I think the N was like in the 20,000 range, because the partial knees have been done in England for like decades. They started doing this in the late 90s, much earlier than we've been doing in the United States.
Yeah, we haven't even talked about chondromalacia, the knee microfracture surgeries. Maybe we'll talk about that.
Yeah, I don't do a ton of that, but there is a role for that. We can always touch on it another time. But yeah, the microfracture is a little bit more rare, but it's
we used to see them a lot more in Boston, probably about 7-8 years ago. But I haven't seen one honestly in probably 2.5 years here, anyways.
Yeah.
Not nearly as often as I see totals and scopes and everything.
Right.
How about a takeaway from you? Anything you want to kind of leave people with?
No, I mean, it's the big thing to remember is that my goal, especially coming from a sports medicine background, is to keep people active. We want to allow you to be as active as you can comfortably be, and that's going to help your heart, your lungs, your back. Everything in your life is going to be better if you can get out and move around. And so when it comes to knee pain, it can be very disabling very quickly and really shut you down. So if you're having a lot of knee pain and, either you don't know why or you do know why, but you're not sure what to do about it, definitely talk to primary care, physical therapist that or definitely come and see an orthopedic person. And we can kind of get to the bottom of it. And there's often a lot of really good treatment options. I mean, as you can see, we barely scratch the surface. There's a million different ways to treat things. And there's often a solution that's really good for you.
I love that. So get a professional opinion. Don't wait. Don't ask your friends how their total knees went. Two friends. I want to avoid that, because what happens is as you age, then you have balance issues and things like that. And if you fall and break a hip or let's just not. We could go down that road, but let's just. Sure. There are bad statistics there. So if you have knee pain, just call and get an opinion, and especially as men, you hate to call the doctor. Just call the doctor. And hopefully we can do something to help. But
we'll never make you do anything. It's giving you options, lots of options.
Exactly, just options are good. It's nice to have options. But right. I just want to say thanks, Phil, for for joining me for a second time here, and really had a good time with this talk. But if you're, I'm going to leave your information in the description of this podcast and the webinar. But if you just want to leave a quick blip, Phil, how people can reach out to you again if they're watching this.
Oh yeah, so WorcesterOrtho.com is our website, and that's for Worcester County Orthopedics. We're in Worcester on the south side near Crompton Park, but I operate at St. Vincent Hospital and the Surgery Center in Shrewsbury. And our phone number is 508-755-0240. And reach out if you'd like to get in touch with us. A lot of insurances will allow you to see an orthopedic specialist right away. Some require primary care referral, and that's okay. We can help help you navigate that too. We have a great staff in the front of our office that can help with all that stuff. So.
Yeah, and if I were to just leave, one more piece, if you do have you have an orthopedic problem, just call Phil directly, because they're, like he said, their office can secure a primary care referral 99% of the time, I'm sure, right?
Absolutely. Yep.
Yeah, great. Well, thanks for the time, Phil. And I think we took an hour and a half. I think we'll probably go for another hour and a half. But
I know, is it too much? I don't know. Hopefully our listeners don't get too bored.
Put some show notes in there. it's funny. I told my PT Sam. She said, try to keep it 45 minutes or so. I said, that's pretty tough, but we can always put some show notes or something. Fast forward to this and talk about that. Yes. So
a little editing.
But great time with you, and we'll do this soon. Sound good?
Yeah, great. Hey, thank you very much, Sean. Thanks for having me.
Yeah, sounds good, Phil. Talk to you soon.
See ya.